Thank you very much for this invitation. It is a great honor to speak to you, your group, and to the participants in this webinar today. Today, I'll talk about the benefits and implementation of ERAS in pancreatic surgery at our center, just talking about our experience over the last 5 years. So we'll talk about 4 things. One is something called the learning healthcare system, in which we can learn academically as we improve our own outcomes. The second, I'll talk about the benefits of enhanced recovery, which I think are pretty obvious, so we won't talk too much about that, but more I'll focus on the implementation and the creation of our pathways that we have. And then we'll talk about the continuous iterative improvements in our pathway that we do every year and a half. So this is a circle of basically what we do in academia. We think of a problem and we try to solve it by analyzing it. So if you go back to 2015 and before, and even now in the United States, the hospital stay, the median hospital stay for a Whipple procedure is 9 to 10 days in the United States, and it has not changed for 2 decades. So in 2016, Dr. Katz, our chief of pancreatic surgery, decided to study this and see what we could do to improve at our center. We collected data on our own outcomes. We analyzed and stratified our own patients because the type of patients we operate will be different than the type of patients that's operated at another hospital. So it's important to analyze your own type of patients. We created pathways and got buy-in from the group of surgeons, the advanced practice providers that are here in the United States as nurse practitioners and physician assistants, and got buy-in from our fellows, our trainees. We got things implemented in September of 2016. And with any process, we have to reanalyze as we take action to change our practice. And we have version 2 that started a couple years ago, and now we're on to version 3. And so I'll tell you the story of this. First, I'd like to talk about what is the whole point of enhanced recovery. A lot of people focus on just the length of stay, and that is part of the equation, but that's not the most important part. The most important part for us is for pancreatic cancer is to avoid something in the United States called non-home discharge. That means sending a patient to rehab, sending a patient to another hospital, sending a patient to the nursing home. To us, that is a failure. We want people to be able to go home. We want people to return to their baseline lifestyle. We want people to be able to start adjuvant therapy within a window of 6 to 8 weeks. And we want people to get back to their normal exercise level that they had before surgery. So that is the real goal of enhanced recovery. To do that, you have multiple points of interaction. At the beginning, and I'll show you, we educate the providers and the patients with simple paper handouts that we give them. We also do prehabilitation that I call Prehab. This is our usual stay, and this is in a cartoon format. And the important parts of this is that in the first 24 hours, probably the most critical, we have to limit the amount of IV fluids and opioids that are given. We avoid transfusions, and we avoid the intensive care unit where patients don't get to walk as much as on the floor. We have pathways tailored to the risk of a patient's complications. We have a low risk and a high risk category. And when you're getting ready to go home or leave the hospital, we standardize the discharge instructions so that the discharge instructions for my patients would be the same as the discharge instructions for one of my partners. So there's no confusion for the patients or for the other providers. We standardized the diet, we standardized even the opioid prescriptions as we try to reduce the amount of opioids, which, as you know, in the United States is a major problem. We also plan a 24 to 48 hour phone call to make sure that they are okay out the hospital. And we also check on them in the clinic less than 1 week after discharge, usually within 2 or 3 days. So the first part is to focus on the beginning. And this is what we do for all our pancreas patients. Of course, we get a pancreas protocol CT scan, we get the biopsies done. But the thing I want to focus on is these 2 things here. Prehabilitation for all ages. It doesn't matter if you're 45 or 85, you will get prehabilitation to get things ready so that you will have a better chance for enhanced recovery. And in a nutrition consultation, regardless of whether you're too thin or too overweight, regardless, we will get you in a situation where you work with a dietitian officially to get stronger. When I talk about handouts, we actually give a piece of paper to the patient, and this is the piece of paper for one of the pathways. We actually talk to them about their anticipated treatment plan And I can share this with your hosts. You don't have to read everything on here. But here I tell the patient, this is your responsibility here. In the clinic, you'll ask the questions that you want to ask. On day one, you'll be walking 7 times minimum on day number 1. On day number 2, you'll start showering on your own. You'll start talking to a dietitian, and so on and so forth. And we give this to the patient ahead of surgery. So they have 2 weeks to read about this ahead of time. And sometimes I give this to them even months ahead of time so they can start thinking about what they need to be preparing for in the hospital. And that helps with the enhanced recovery. The first 24 hours are perhaps the most critical, and it's almost like running a race. You have to get out of the starting block in a good position to start moving quickly. So we have order sets, like most hospitals, computerized, and this eliminates the variation in care. Instead of having to re-explain the orders to every single resident or fellow every single time you do an operation, it's relatively standardized so that 95% of the orders are pretty set. To me, enhanced recovery is not so much pushing the gas pedal to drive the car faster. Instead, it's avoiding hitting the brakes when you drive a car, and it keeps slowing it down and prevent you from moving along in a continuous pace. That's what enhanced recovery is. And the brakes that slow us down in surgery are excess IV fluids and too many opioids here in the United States, which leads to ileus and gastroparesis. Using electronic order sets will limit the fluids, will limit the opioids, and allow us to use non-opioid medications, and allows us to avoid using the intensive care unit. We never send a patient to an intensive care unit. They go to the floor with monitoring. I want to focus the majority of my talk on the risk stratified pathways. So pancreatic leak, as we all know, is relatively predictable. Now, certainly the leak rate can depend on different hospitals based on what type of patients you typically operate. Do you have more adenocarcinoma? Do you have more non-cancer patients? Do you have more neuroendocrine? So it all depends, but you should look at your type of patients. So we looked at this back in 2016, and we had a very high fistula rate in those very, very high-risk patients like duodenal cancer, things like that, with a very small duct. But in most patients with pancreas adenocarcinoma, the leak rate was extremely low. So why were we treating every single person the same? It doesn't make any sense. We were slowing down the people who could go faster. So we created 3 pathways based on your risk of pancreatic leak. You can see these are things that are different from the fistula risk score that everybody's familiar with. The fistula risk score requires measurements in the operating room, including your blood loss. These are things that we need to know before surgery in the clinic. So we look at what operation, the diagnosis, the pancreatic duct diameter, and the body mass index. And based on this, there's 3 pathways, which we actually use a color-coded system. So it's very easy for a patient: green, orange, or blue color piece of paper. High-risk high-risk pancreatic duodenectomy, low-risk pancreatic duodenectomy, and then just a distal pancreatectomy, whether minimally invasive or open. So this is, I showed you the paper that we give to the patients. This is the paper we give to our fellows and residents, and now it's pretty much memorized, but this is very important because it allows us to know what we're doing and should be doing. You can see here, this is the most recent version that we have here. This shows the same pathway to figure out this particular patient is a green pathway patient. They're having a Whipple procedure, they have adenocarcinoma, and so they're a green pathway. You can see that our leak rate is about 4% of these patients for adenocarcinoma, so it makes sense for this person to be a faster track patient. In here, you can see in the bold font, these are the things that are required. In the light font, you can have some variation in care you're allowed. And we'll talk about how we came up with these. And every single day, these are the requirements, and then with a goal to try to leave the hospital by post-op day 5. Okay. At the bottom for our database, we have a prospective database that's reviewed by Dr. Katz and 2 nurse practitioners every 2 weeks. And we continue this for 90 days. So at the bottom, this is how we measure the compliance within our own hospital group. Back before 2016, we mapped out the length of stay for our patients. So you can see we were not much different than the rest of the United States, which to me is bad. Nobody wants to be average, right? So our median length of stay was 9 days for the low risk and 10 days for the high risk. And so you can see that the low risk patients were being held back because we treated everybody the same. The other thing on this graph you want to see here, length of stay is in the y-axis, and the x-axis is the age of the patient from young to very old, 85. You can see the variation in length of stay. It's all over the place. You can see all these dots everywhere, very wide range. When we implemented the first pathways, and I'm just showing you the low risk green color patients. These are the green piece of paper we give them. These are the people who are going to be faster. With the pathway, you see two things that are very obvious. Of course, the median came down very quickly, but more importantly, the variation was narrowed significantly. You can see that there's only a few outliers, and most people are hovering in this lower range where the length of stay dropped to a median of 6. And this includes people who are 60, 70 years old, 75, 80, 83 years old. It includes people who have vein resection and even artery and vein. And so the point is narrowing the range to reduce the, which is based on reducing the variation in care. The next two things we wanted to focus on after just length of stay is what are the specific improvements that we can make as we go from version number 1 to version 2 and version 3. The first was a focus on drain management, and the second was on nasogastric tube or an NG tube management, which we'll talk about. So I'm a big proponent, we're a big proponent on using hospital-specific drain fluid amylase cutoffs. There are millions of papers in the literature on drain fluid amylase cutoffs for when your drain is removed. But why do I care what drain fluid cutoff is used in a hospital 5,000 miles away? That means nothing to me because those are not the patients I'm operating on. I should look at what type of patients come to my hospital and look at my own outcomes. So we created a sensitivity chart based on amylase cutoffs. For example, here's a high-risk pancreaticoduodenectomy or Whipple procedure, drain fluid amylase on day 1, drain fluid amylase on day 3. The other thing you have to keep in mind is that different surgeons have different tolerance of risk. Some surgeons will be very conservative and say, I will not remove a drain unless 100% chance of no continued leak or need for interventional radiology. And some surgeons will say, well, 80% or 90% is okay. And you might say, well, nobody accepts such a low level as 80%. But in reality, if you use some of those traditional numbers, such as there are publications in the United States say using a cutoff of 5,000 amylase on day number 1. If you use that, the sensitivity on that is 55% of our patients. You might as well be flipping a coin in the air, seeing heads or tails to see whether or not the patient will have a problem. So based on your conservative nature, you will have different cutoff levels. Do you want to wait to 100% sensitivity and go very low on the amylase, or are you better at this level? So this allows the doctor to choose what their comfort level is for the drain removal on day number 1 or day number 3. The point here, though, is to ensure that all our partners were moving the drain by day 3 when possible. We then wanted to also address delayed gastric emptying, which, as you know, is a big problem with Whipple procedures. Literature says it can happen up to 20-something% of patients, 20-30% of patients can have some sort. Our rates were very high as well. You can see by just starting the pathways in 2016, just doing a pathway, you can see that our delayed gastric emptying rates went down dramatically already from before 2016 to the 3 years after 2016, the different types of DGE. This is the same graph as shown by high risk and low risk. So both the high risk and low risk, both pathways reduced their delayed gastric emptying rates. When we analyzed the factors that had to do with delayed gastric emptying, of course, you can see that an abscess is a major factor for delayed gastric emptying. And there was a trend toward using hand sewn instead of using stapled. But the main thing that we notice is that getting the nasogastric tube out before 2 days, less than 48 hours, is the best thing. Getting the nasogastric tube. If you leave the nasogastric tube too long, then the patient will inevitably end up with delayed gastric emptying. Now, I know a lot of surgeons say, well, if you take it out too early, there's a risk that they will have an NG tube reinsertion. And we looked into that, and the nasogastric tube reinsertion rate is extremely low, less than 10%. And so why should we hold back 90% of our patients because 10% might need a nasogastric tube for an extra day or 2? So that's the whole point of enhanced recovery. Don't drag down everybody because a small group might have a problem. So if you compare our newer versions to our first version, I think this is a big thing, the nasogastric tube, that if you remove the nasogastric tube by day number 1, this is the red color, then you can see that it's more likely that a patient will start their regular diet at a sooner rate. So you can see the bars are shifted to the left, while the gray is people who have the nasogastric tube for 2 or more days. And in these patients, their first day of regular diet is going to be shifted more toward post-op day 5, while the other people get started on regular diet post-op day 3 or day 4. As you know, one of the criteria for discharge is the ability to eat well for at least 24 hours. So the sooner you get that going, the sooner the patient can leave the hospital. I have to say one thing here. Length of stay by itself, again, is not the goal. We're not just trying to accelerate patients out of the hospital, but this does get them jump-started in the recovery process. In the past year and a half, it has actually been very helpful. We further reduced the length of stay because in our hospital, at least, a family member is not allowed to be in the hospital with the patient right now because of COVID. And so the sooner we can get a patient healed and get them ready to be outside the hospital, they can go back to having their family member help take care of them, because if they're in the hospital, they're by themselves. So you can see between the newer version and the first version of our pathway, we're more likely to remove the nasal tube by post-op day 1, doubling the number of people who get the nasal tube out. So it's not 100%, and you don't have to go from first iteration to perfect in one move. It's just about seeing an improvement. You can see also on day number 1, the drain removal, we've doubled the number of people who get their drain out early, and that lets patients feel more comfortable. They don't have a drain sticking out their side. They're moving around better, walking better, that sort of thing. Again, if you compare the version 2 versus version 1, you can see even in the low-risk patients, keep in mind, we made a major drop in 2016. We went from 9 days down to 6 days within 1 year, 3-day difference. And then what you can see here is that we dropped 1 more day in the last couple years by just further tweaking and adjusting the nasogastric tube and drain management. The biggest change has been in the orange color sheets that we give patients. It's the high-risk patients, the ones that have a higher risk for leak. Why are they improving so much? Keep in mind that the median was 10 days and down to 9 with the first iteration, and then now down to 6 with the most current version. It's because as we start seeing how well the green patients can do, we see that there's actually a sub-cohort of the orange color patients, the high-risk patients, that are kind of more like the green, and they can benefit from the benchmarks that we have for the green patients. So we've created hospital-specific drain removal criteria, reduced the number of days of nasogastric tube treatment, and you can see here that we are down quite low now to 5 to 7 days in our patients. So it's a huge decrease in my opinion. I won't focus on this too much, but the final thing, again, before discharge, is to standardize your prescriptions, your instructions for the patients. There's no confusion for readmission to the emergency room because of some sort of confusion, some problem. So this is my summary slide. For us to be able to have a Whipple procedure patient go home on post-op day 6, avoiding readmissions, be able to get started on the recovery process so they can go home, get on adjuvant therapy, return to work, get back to their normal life. It actually all starts pre-operatively. It is not just what we do in the hospital. It all starts before surgery. Thank you.